Hi, everyone. Thank you for joining NATS Online Support Group. We are joined this evening by Dr. Jim Welker and Drs. Bill Auger, and we're going to be discussing CTEPH, who, with many of you with pulmonary embolism, this is, something that either you're dealing with or you have concerns, you might be dealing with it in the future. So we're really fortunate to have Dr. Welker and Dr. Auger with us. Dr. Ajay has a little bit of technical difficulty joining the call, so he's not on at the moment, but should be joining momentarily. So I'm going to open it up to Dr. Welker to go ahead and get us started.
All right, so thank you everyone for joining us tonight. I've talked in the past about the how we're trying to help everyone and the importance of these types of events. We're certainly seeing an increased role of patient self-determination in regards to their health care. And so, obviously, we hope programs like this help you achieve that. And along that lines, for those of you who may not have heard of this book or read it, there's a book by Dr. Toprol called "The Patient Will See You Now." And he's a cardiologist that was at Hopkins and then went out to the Cleveland Clinic, and now he's at the Scripps Institute in San Diego. And this book is interesting because it gives his vision of the self-empowerment that's occurring. He focuses a lot on cell phones, but conceptually it's the idea of technology creation of the artificial intelligence and the way it's helping with diagnostics and helping with and thought that eventually as time goes on, well, there's been a movement all along. 20 years ago when I started this, most things doctors did were memorized and very, this is what you do, and that was the end of the conversation. Now things are much more dynamic. There's a discussion of options. There's extensive discussions. There's expectation of patient participation, decision making, and I think Dr. Toprol in his book is making the point that that'll continue, and patients will come to the doctor and say, well, this is what I need from you, and I don't know if we'll get there in my lifetime, but certainly we've certainly seen a progression down those lines. And so obviously programs like this are to help you use what you've been reading and learning and bring it together so you can help take better care of yourself. So tonight's format's intended to be a interview style format. So once Dr. Auger is available, we'll get it.
I have voice. This is Bill. Hi, everybody.
Oh, very good. Perfect.
But I don't have.
Voice is good.
Okay, voice. We're going to have to go with voice tonight.
If we get to the point where there's some slides, we'll look at those. But we're certainly happy with the voice.
I'm sorry, everybody. Having technical issues here. So why don't you go ahead, Jim?
So good timing. I was just saying that tonight will be interview style, and you're our guest as you always have been for the past year with the CTEPH. And so first, I want to start out with so tell us where you are now. You switched institutions, and tell us a little bit about how that's going and or so forth.
Well, actually, for many years I was at UCSD Medical Center as the director of their CTEPH program, and recently retired, and I was given the grand opportunity to continue my work here at Temple University in Philadelphia, and I'm very delighted to be here at this wonderful medical center. It provides a full range of services for patients with pulmonary hypertension and for patients with chronic thromboembolic pulmonary hypertension, medical therapy, balloon pulmonary angioplasty, as well as thromboendarterectomy surgery. So I've been here since November of 2018, working hard. A lot of patients, I feel, are benefiting from this fine organization and the good work that they do. So it's been a wonderful transition, and I'm very proud to be a member of their team.
So now, just so everyone understands this, UCSD under your leadership was consistently by quite a margin compared to other centers in the country, the busiest CTEPH center in the country, and so and there's dozens of them in the country, and so your definition of retirement is going to the second busiest CTEPH program in the country.
Okay, so everybody online now knows perhaps my judgment is not the best, but I feel that I feel very passionate about this particular area of medicine. I've been involved with it my entire career since the mid-1980s, and feeling that I still had some tread on my tires, I felt that I wanted to engage in patient care and to continue with the work that I did back west to see if we can't develop the San Diego of the East here. This is the second largest or second busiest program in the United States, and it's only gotten busier since I've been here. So, there's in this day and age, for those of you online with us this evening, you all very much realize that it's not always easy to travel far distances in order to receive your health care, and it's important that we continue our work to provide this level of service for patients in need throughout the United States, and so that at least certainly on the East Coast now there are a number of medical centers that deal with patients with chronic thromboembolic pulmonary hypertension and can help them receive the care that they require.
And then, if I remember correctly, you were telling me there's you just got done writing a book about CTEPH. Why don't you tell us about the book and when it'll be available and where people might be able to get it and things like that?
Well, it continues to be a project. If any of you out there have ever written a book and work with publishers, it's a long-term problem, but it is a series of clinical cases of patients with chronic thromboembolic disease to educate physicians and care providers in particular, but of course, in this day and age, it's just as important that patients and their families be educated as well about the disease. It hopefully will be a useful tool of how patients present and how one goes about making the diagnosis of CTEPH and what can be done for it, as well as some of the mimics that occur, some other disease states that look like CTEPH that in fact are not CTEPH. So this is a series of cases that will help the clinician better diagnose and care for patients with chronic thromboembolic disease. It should hopefully be done by the end of spring, but I'm trying to be optimistic. And so perhaps at our next online support group, I can give you more details.
More details? Okay, good. Let me, there's a couple questions that came in today. Let me start with one of those. Because in this one, both I'll give some thoughts and then you can sort of, smooth out the rough comments and make it understandable. But I think, so here's the question. The patient began by describing the extensive PEs in the upper lobes of both lungs in 2011, no indication of DVT, high blood pressure and obesity, and was on a blood pressure medicine at the time of the event, losartan. And he or she has always been told that with weight loss, they'll probably be able to go off the blood pressure medicine. And he says, he or she says, as of today, lost 15 pounds over about a month and a half. This is 1.2 months due to going on thyroid medicine. They found out the patient had Hashimoto's hypothyroid disease. And So the question was, they've never had another, if they never have another P event at this point, so we're talking 8 years later, is there a chance that they can have CTEPH, or they pass that risk? And then the second question is this question of, is there any association between high blood pressure and CTEPH? And so, you know, let me comment on both those, and I'll hand it over to you, Dr. Auger, to really round it out for us. But, you know, so one is this common connection that people try to connect hypertension, systemic hypertension, to CTEPH. And there's really no known association. You know, these are viewed as different diseases. So hypertension is systemic hypertension, where they check your blood pressure cuff on your arm. Your blood pressure is elevated, and most people, we don't know why that occurs. It's just who they are. Certainly, some people have associations like have things like associations like they're overweight, and some overweight people lose weight and their blood pressure comes down to a level that they don't have to take medicines. But many patients, they lose some weight and they don't need as many medications, but many of them still need medications. Other associations like alcohol use raises blood pressure, but most people we don't have a clear known source other high blood pressure, and they get treated with medications for it, and that is unrelated with pulmonary pressures. So your pulmonary pressures don't necessarily correlate with the systemic pressures, as we say. And then where CTEPH specifically referring to the idea that you had thromboembolic disease of the pulmonary arteries, and it's one cause of pulmonary hypertension, one specific cause of pulmonary hypertension. And people with CTEPH, the systemic blood pressure is the blood pressure when they check your arm. It doesn't fluctuate with CTEPH unless you're severe end stage case of it. But so that's association with blood pressure and the CTEPH. And then the other question is also very interesting. This question of when are you no longer at risk to develop CTEPH, which is a very interesting question, and it also gets into this idea of and in that category, I think we would also be thinking about post-pulmonary embolism syndrome, or what some people now, in the newest term I saw, is post-PE impairment. And to give you an idea of just when I say where we set the bar, I remember very well at a meeting that Dr. Auger and I were, and Catherine was there, from the CTEPH folks were there a year and a half ago, where this Olympic swimmer was talking about her experience with developing a PE, and her change in her life was that she could never compete again after a PE because she couldn't swim as fast as she used to. And so that's not a measurement in which we now call post-PE syndrome, but she certainly had a change in her performance status after her PE. It seems like so. When the risk ends, when are we even aware that someone's having some impact on their body? That's a complicated subject there. But so Dr. Auger, obviously we need to hear your comments on these two questions.
Well, thank you very much. The first, let me just start with the second question first, and that is there a link between the high blood pressure that people talk about, and a lot of people do suffer from, where you measure with a blood pressure cuff, you measure the blood pressure in your arm, and that is the type of hypertension that is linked to various kinds of left heart disease, and there is no known association between that kind of blood pressure, the high blood pressure that we measure every day in our doctor's office, versus pulmonary hypertension of any sort, and certainly not chronic thromboembolic disease. So I can assure everybody out there that that kind of high blood pressure is not linked to pulmonary hypertension and or CTEPH. Okay, and so the first question, and let me try. I missed part of the initial story. The question that was being asked was I had a blood pressure. Hang on, I had a pulmonary embolism at some point, and
so apparently 2011.
Okay,
good. No pulmonary embolism since then. And correct. The question was, here 8 years later, is there an ongoing risk? Should they be considering it?
Right. And that is really a very important question, and I think it hopefully folks will chime in at this point because I know a lot of people think about it. There's, it starts with, listen, I had a pulmonary embolism 2 years ago, and now I'm still short of breath despite being on anticoagulants. I can't do what I want to do. Should I worry about chronic blood clots or CTEPH? And it is something that needs to be thought about by you and your physicians, because we don't really know between the pulmonary embolism that folks experience, the development of chronic blood clots, and then the development of CTEPH. We really don't know how long that takes. And I think there's a lot of individual differences. So in some people, we see it happen within 6 to 8 months. But to be honest with you, we've had many patients who ultimately are diagnosed with CTEPH who frankly had their first blood clot 10 years ago, 15 years ago. And so it is possible that within this time span, there have been more blood clots, be they silent or be they symptomatic. It sometimes takes a long time to go from acute to chronic thromboembolic disease and to slowly but surely develop pulmonary hypertension. And everybody's different. And so, yes, if you do have symptoms, even if you've had your blood clot many, many years ago and been on anticoagulants, and even if there was a period of time where you got back to your normal state and now subsequently you're having shortness of breath, talk to your doctor about, is it possible for me to have chronic blood clots? Is it possible for me to have CTEPH? And it may not be linked, but it's very something that one needs to think about. And so I know that isn't a definite answer, but this has been the problem for many, many years, is that people often don't realize that CTEPH can develop many years after having experienced an acute pulmonary embolism.
And I guess another concept, if I understand correctly, is there are people that don't have profound, noticeable, persistent acute symptoms, sometimes with recurrent thrombus, right? Because you see some people that they don't even ever have a diagnosis of acute PE that develop CTEPH, right? So that could be going on along the way too, right?
Yes.
So you have several reasons why you can have very late. So tell us about the typical symptoms. So in this patient, if they were, if physically they're doing quite well, and then they develop some new symptoms, what would make them think, I should talk to my doctor?
Well, especially if you and many of the folks on the webinar tonight might have had a pulmonary embolism in the past, and the vast majority of folks having received anticoagulant therapy, those clots are going to go away, and it is hoped that you will get back to a level of activity, a level of functional status that you're accustomed to, that you want to get back to. And the vast majority of folks with anticoagulants are going to get back there. But there are some folks that even with anticoagulants will still just not feel right. Listen, I just can't do what I used to be able to do before I had my pulmonary embolism. You know, I'm a little more short of breath. I can't exercise as much. I can't go upstairs as much as I used to be able to without getting short of breath. And the kind of the persistent symptoms, even though you've had a course of anticoagulant therapy, should be further evaluated. Now, I need to warn everybody that that doesn't mean you have CTEPH. It doesn't mean you have chronic blood clots. There may be other things that are going on that are simply related to some of the other problems you might be experiencing, medical problems you might be experiencing. But it's important to recognize that it might be chronic thromboembolic disease or chronic blood clots. And the good news is that if it is chronic blood clots, you know, we can really do a lot for that. And so you shouldn't miss the opportunity that if you're having persistent symptoms, especially if you've had a history of pulmonary embolism in the past, talk to your doctor and really raise this issue as a possibility. For some patients, you know, and this is we see this often in patients with diagnosed pulmonary hypertension. Even if you didn't have a history of pulmonary embolism, make sure your doctor has ruled out CTEPH. And so for those folks on the call or on the call this evening, if you do have pulmonary hypertension and you're seeing a doctor for your pulmonary hypertension, make sure they've ruled out CTEPH. And the third group of folks in which chronic thromboembolic disease and CTEPH need to be considered, for those folks that, you know, who have developed kind of an exercise intolerance, you know, I can't do as much as I used to, you know, last year or 6 months ago, you know, I'm short of breath with exertion, and, you know, I was fine, you know, last year, and really nothing dramatic has happened. You haven't developed COPD all of a sudden, or you haven't really, you know, developed a heart problem or a lung problem, and there's really no evident reason. You know, a lot of us say that, oh, I just gained weight, or oh, I'm just getting a bit older, but if it just doesn't feel right, if that explanation just doesn't feel right to you, talk to your doctor about making sure that you don't have pulmonary hypertension, you don't have right heart strain, and particularly if you don't have chronic blood clots, even if you haven't had a prior history of a clot in your leg or a clot in your lungs. And so, and I call this, you know, shortness of breath with exertion for no evident reason. And we see this a lot in younger people, 20-year-olds, 30-year-olds, and that all of a sudden, you know, and last year they were playing soccer, but this year they're just, you know, are short of breath, you know, walking across the room. That just ain't right. There's something one needs to really talk to their doctor about, and don't ignore it. And the reason why we spend the time on these webinars, and I'm very grateful to NATF for sponsoring these webinars, is it's so important to recognize this disease of chronic clots, of CTEPH, because there's so much we can do for this, and to get people feeling better.
So now, how about any associated conditions, you know, we call them risk factors, but associated conditions that patients might have that they might the risk, you know, would be higher to develop CTEPH after they had a PE. What kind of things should patients think about that they would be familiar with?
Have you guys accessed my slides? because I'm back on. I've handled my technical difficulties. If you can capture my screen, I have slides. I don't know if that's possible.
Yeah, Dr. J, I'm just going to do the same thing that we did earlier today and just make you the presenter so we can see your screen.
Okay, because I do have a slide to help answer the question that Dr. Welker just asked.
Okay, sure. So I will do that now. Let's see, make presenter.
Okay, and I'll just start because I don't want dead time on the phone here.
You should have gotten something.
Okay, and so let's see here. Yeah. Okay, I'm just going to go ahead. And there, first of all, Dr. Welker just asked, what are the risk factors for developing CTEPH? Oh, here we go. What are some of the risk factors? Oops, I just lost it.
I can see it.
Yeah, we can see it.
Everybody can see it except for me now.
Well, now we see your desktop, so if you have anything.
Okay, well, I'll just do it from memory. First of all, one of the risk factors, let's say you've experienced a pulmonary embolism, and if the pulmonary embolus is large, if there was already signs that your right heart was strained when you first presented with your pulmonary embolism, if the pulmonary embolism was what we refer to as unprovoked, really there was no clear reason why one developed a blood clot, and that even after anticoagulant therapy in the hospital, you left the hospital with some pulmonary hypertension. If you had symptoms longer than 2 weeks prior to your presentation of having an acute pulmonary embolism, and those of us who are older than 60 years of age, these are kind of risk factors related to the time surrounding your acute pulmonary embolism that your doctor needs to pay attention to, that you might be at higher risk for developing chronic blood clots or CTEPH. So those are the risk factors as it relates to the first episode of pulmonary embolism. Okay? Now, are there medical conditions that have a greater link that place people at risk for developing chronic thromboembolic disease? We know that if you've had a prior history of a malignancy, we know that if you're on thyroid medications, we know that if you have a chronic intravascular device, such as a ventricular atrial shunt for those patients with hydrocephalus, for those patients with pacemaker wires, for those folks with chronic indwelling vascular catheters like portacaths. We know that if you've had your spleen taken out, and we also know that certain forms of chronic inflammatory disease like Crohn's disease or ulcerative colitis, these are kind of medical conditions that are felt to be more commonly seen in patients who ultimately develop CTEPH than in those patients who don't go on to develop chronic thromboembolic disease. Okay, does that answer the question?
Yeah, very nice. So reasons to think about it, and I don't know if maybe if our attendee tonight might have been thinking about their thyroid replacement. Maybe that's why they started to get concerned. Maybe they read somewhere of association there. So
yeah. But it's important to know, again, one needs to be educated about these kinds of things. There are a lot of people on thyroid replacement medications that don't develop CTEPH. It's just that we've noticed over the years that all the patients that we've taken care of with CTEPH, the number of folks who are on thyroid medicines are much greater than those people who have a PE and that PE goes away on antithrombotic therapy. That's all this really means.
Right. So let's say, so someone like our patient that was described there, if they have some symptoms and they think they are worried that maybe they've have CTEPH, even though it's many years later, and as you point out, you encourage them to talk to their doctor. So they start seeing some doctors. Let's talk about the tests that they might do to arrive at a diagnosis of CTEPH.
There you go. And you're setting me up perfectly tonight, Jim. Okay, you'll see the slide here that's entitled Evaluation for CTEPH. And you'll see here that in order for want anybody to make the diagnosis of CTEPH, you got to suspect it. And these are the three patient groups that I talked about earlier. Those patients who have had a history of having had an acute pulmonary embolism, who have persistent heart or lung type symptoms, mostly shortness of breath or a decrease in exercise capabilities. And these symptoms persist even after a course of anticoagulant therapy. Those patients who have pulmonary hypertension or high blood pressure within the pulmonary vessels, all of those patients need to be screened for CTEPH. And for those individuals who have unexplained exertional dyspnea, that unexplained shortness of breath with exertion, I can't go up the stairs like I used to. I can't walk more than a couple of city blocks. And, last year I was just fine. Even if you don't have a history of thromboembolic disease, these are the three major groups of folks that really need to be screened, first for pulmonary hypertension or pulmonary vascular disease or CTEPH. What do you do? Well, the doctor should order an echocardiogram. That's an ultrasound machine that's actually a wand is placed over your chest. Actually, you can take pictures of your heart with ultrasound, and we get a good sense of how big your heart is, both the left side of your heart, the right side of your heart. We can actually get an estimate of pressures within your heart. So the doctor is screening you for pulmonary hypertension or right heart strain. That's very important. And to screen for CTEPH or for chronic thromboembolic disease, a lung scan should be obtained. That's a beautiful screening study. So if there are defects on the lung scan, one needs to consider that there might be chronic blood clots there. Now, let me just take a minute to explain what I mean by a lung scan, a lung ventilation perfusion scan. And I'll just stick with the perfusion part. There's a little bit of radionuclide, a little bit of material that's injected into a vein. And this kind of material, it's just albumin. It's just safe. It's very safe. It's a kind of protein that's in our body already, and it's just labeled with a little tracer. And what happens is that this material follows the path of the blood vessels. It goes from the veins, through the right side of the heart, through the right atrium, and into the right ventricle. And the right ventricle contracts and pushes that tracer into the lungs. And as I said, this tracer follows the blood vessels, the blood streaming through your lungs. You can imagine if you have a blood clot in your pulmonary artery, which is the blood vessel that goes to your lungs, if that is plugged up with an old blood clot, the tracer will not get into the lung fields. And so what the scan shows is a defect, an absence of blood, where there is an old blood clot. So that this is a good screening study for occlusion or obstruction of your pulmonary arteries due to old blood clots. So if the perfusion scan is absolutely normal, meaning that there's blood flowing to each region of your lung, then you don't have CTEPH. But if you have a defect, if you have a perfusion abnormality in your lung field, then you need to go ahead and have your doctor, or your doctor should go ahead and actually perform more diagnostic studies, such as a CT scan or a pulmonary angiogram, which again gives you pictures of your pulmonary arteries. And these kinds of studies confirm the diagnosis of chronic thromboembolic disease. And after that occurs, you will be in a better position to seek advice from a medical group or a pulmonary hypertension center that has expertise in not only diagnosing CTEPH, but in caring for patients with CTEPH.
Very nice. And what about, how about some other tests that we hear about, like pulmonary function tests? Do you do that at all in your assessment of these patients?
Well, we do, but they try to answer different questions. And the pulmonary function tests are breathing tests. It gives you a measure of the volume of air that goes in and out of your lungs, and it measures something quite different than what we're trying to do in diagnosing CTEPH. CTEPH is within the blood vessels that go to your lungs. Okay, and it is you can kind of consider it like this. Your heart, your right side of your heart pumps blood to your lungs, okay? And it pumps the unoxygenated blood from our veins, from our tissue, to your lungs to get oxygenated again. So the heart's like a pump, and it's pumping blood into your pulmonary arteries, which you can consider to be like pipes. And you can imagine that if you have a pump, like a water pump, pumping water into a pipe, and that pipe is getting obstructed or plugged up with material, boy, it gets really hard for that pump to pump water into those pipes. The same thing for the heart. The heart is pumping blood to your lungs through your pulmonary arteries, and if those pulmonary arteries are starting to get plugged up with old blood clots, which are that have narrowed or plugged up those pulmonary arteries, it gets harder and harder for the heart to pump blood to the lungs. And that's what is meant by pulmonary hypertension and right heart strain. Okay? And so the pulmonary function tests that you were asking about really kind of measure lung volumes, the air in your lungs, and it measures the function of the airways going in and out of your lungs, not the blood vessels going in and out of your lungs.
So I guess what happens if a patient has experienced a workup and had a PFT in the middle of the workup, these situations a lot of times are very challenging to diagnose sometimes, right? And so probably the times where doctors get a PFT is whenever they're trying to sort out exactly the entire lung physiology, and maybe there's other reasons
Correct.
for the breathing problems, things like that, right?
Yeah, that's right. They're looking for something else that might be causing your shortness of breath. That is correct.
And
good.
Dr. Welker, if I could just interrupt for just a moment. When you get a second, we did have another question come in over the chat. So when you're ready for it, I'm happy to share it.
Oh, sure. Oh, you could just say it, or if you want forward to me, I can look at it, or whatever you want.
So this patient was wondering if you could get CTEPH if you stay on a prophylactic anticoagulant. They were diagnosed with extensive bilateral PEs in November. The cardiologist says they'll stay on half dose after 6 months, maybe forever. They're a 58-year-old female. Just an FYI, they were in the emergency room this past Sunday with right-sided chest pain. Not bad, but worrisome after recent findings. And all the PEs are cleared. So the question, I think, is if you stay on an anticoagulant, can you develop CTEPH?
Yes. Yes. If you have had a pulmonary embolism in the past, even on anticoagulant therapy, sometimes those clots won't go away. And if you're having persistent symptoms, shortness of breath, and difficulties, then you will need an evaluation for CTEPH.
Yeah, I feel like, and correct me if you disagree, but I feel like one of there's with all diseases in medicine, there's things that they're treated similarly and they're stable understanding for years, and then there's areas where we have an expanding understanding of nuances of the disease that are more subtle to patients, and therefore we need to pay closer. We can pay closer attention. We can do more diagnostic tests, and I feel like in the area of PE, this concept of post-PE syndrome, potential development of CTEPH, that's a rapidly growing area. Whereas 10 years ago, I think it was very common that a patient got diagnosed with PE by an ER doctor, told to take anticoagulants for 3 months. They saw their primary care doctor. After 3 months, they stopped the anticoagulants, and no one thought about it anymore. I think now, I feel like, we're at a point where a lot more attention in that follow-up period and a lot more assessment of symptoms and full resolution of disease is an area we're at now. What do you think about those thoughts? You think that's an accurate, valid statement?
Absolutely. I couldn't agree with you more. I think so much we understand so much more about what happens after a pulmonary embolism, and the space between acute pulmonary embolism and chronic pulmonary embolism is really being filled in about a greater understanding of what patients experience after they've had a pulmonary embolism, even with anticoagulation. There is this concept that you now see on your screen of a post-PE syndrome, in which CTEPH and chronic thromboembolic disease are only a small fraction of folks who have had a PE in the past. And there are a number of conditions and there are a number of reasons why people have persistent symptoms after a pulmonary embolism. So it's not in patients' heads that, gee whiz, I just don't feel as good as I used to before my pulmonary embolism. There are a lot of physiologic reasons why people experience some of the problems that they experience after a treated PE, only one of which is the development of chronic blood clots or CTEPH. So we've learned so much over the past decade about this. And the good news, we can do so much for folks now who really are still experiencing some difficulties after having a pulmonary embolism. And so it's all good news. And to have webinars like this is to a large extent really, really important. So really folks can advocate for themselves and say, listen, what is the problem? And it's very important to talk to your doctor, to reach out to somebody if you have questions about why you're still perhaps not feeling as well as you anticipated after you've had your treated pulmonary embolism.
And I think you and I share in this sort of concept of the value of this. We keep emphasizing it. I mean, and it's not that it's the primary care doctors in particular are doing and general pulmonologists and hematologists, they're doing the best they can. It's just that when things evolve, as this is evolving year by year right now, it takes decades for it to filter in through the rest of the medical system. Things that
I agree.
It takes a long time, and so that's why it's important for us to get to help patients understand, like you're pointing out.
Absolutely.
So another test that I had a patient sent for in their workup of their unexplained dyspnea, is the CPET test, the cardiopulmonary exercise test. Share with us some thoughts on that test and how that might lead one to think about pulmonary vascular disease rather than other diseases or not.
Well, there are all degrees of problems that occur after people have experienced a pulmonary embolism, and some more severe than others. And we've spent a lot of time this evening talking about one of the more, the extreme forms, such as CTEPH. But people can go on to develop chronic blood clots within their pulmonary arteries that can be, not lead to pulmonary hypertension or not lead to heart strain, but it can lead to, I'm breathing harder than I used to, because now you have a piece of your lung that's not receiving blood flow, but you're still putting air into and out of your lung. And some of these more subtle forms of chronic thromboembolic disease, some of these more subtle forms of shortness of breath after a pulmonary embolism can be picked up by doing an exercise study in which the doctor can watch your gas exchange, can watch your oxygen levels, can watch your degree of how much carbon dioxide you produce while you're exercising, and we can gather that information up. And there are certain patterns that we've come to associate with, there may be a physiologic reason why you're short of breath that isn't to the severe form of, let's say, CTEPH, but it's still enough for you to feel it and for you to experience some problems after having a pulmonary embolism. And the folks that usually experience this kind of problem are typically younger individuals. You had mentioned previously, Jim, an athlete who was probably used to doing, major exercise, and yet after the pulmonary embolism, just wasn't able to do it anymore. And some of these subtle decreases in exercise capabilities due to blood clots can be picked up by these high-level exercise studies. And again, these are done by pulmonologists and cardiologists who are experienced in doing exercise testing and that can interpret the tests appropriately.
So, how about I don't know what you can share with us on the the future of screening for pulmonary hypertension. I think you told me you're doing some work in that area. What can you share with us about as what we might see in the future?
Well, we've talked about a lot of it today. Some simple studies like getting a lung ventilation perfusion scan is very helpful. Doing exercise testing can be very helpful, but again, these are kinds of things that are done by specialized centers. The lung scan is available everywhere, but the exercise studies are done by specialized centers. And so the real challenge for all of us in the field is how can we diagnose these diseases, through the studies that we routinely get to, let's say, diagnose acute pulmonary embolism. And as those on the phone know, that if you've had a pulmonary embolism, you've probably had a CAT scan. And the appearance of pulmonary emboli, acute pulmonary emboli in CAT scan is pretty well known. And most radiologists, actually the vast majority, almost all radiologists, absolutely know what an acute blood clot looks like on a CAT scan. Well, sometimes it's a little bit harder to pick up chronic pulmonary emboli on a CAT scan. That's the reason why the perfusion, the lung ventilation perfusion scan is a good screening study, because it's easier to read. But sometimes all that is ordered is a CAT scan. And right now, one of the projects I'm working on is actually an artificial intelligence project in which we're teaching a computer how to read CAT scans more accurately as it relates to chronic thromboembolic disease. So that's kind of an exciting project that we're currently doing, and that's, kind of the future sense, and to help our radiology colleagues better diagnose chronic thromboembolic disease on a routine radiographic study like a CAT scan.
Very nice. Let me read. We're running out of time. There was another question that came in. I want to make sure I answer the patient's questions, because probably the most relevant thing here. So let me read this. This is a long question. We'll see if we can get through this. So the patient says, I've had 2 PEs, but complained of calf pain for days before the PE was diagnosed. By the time an ultrasound of my calf was done, there was no sign of a DVT. Though a medical technician said my symptoms I complained about previously seemed textbook classic of DVT. So that's just the first couple of sentences. And conceptually there is the possibility that you had DVT that moved out of there and went to your lungs, and
sure, that's possible.
No residual. Yeah.
Well, yeah.
All right. I'm sorry.
No, go ahead.
So then continue on. It says my first PE was 2007, and I was on Coumadin for 8 months. I was treated with Coumadin for 8 months, taken off with Coumadin due to unconfirmed internal bleeding. And my second PE was in January 2015. I was put on Xarelto. And it says at that time, the patient was told they were allergic to Coumadin. Then said that their blood pressure would suddenly drop throughout the day, and they would even have syncopal episodes. They'd pass out. But it sounds like there was multiple doctors involved, because it sounds like there's some debate about why exactly this is happening, because it gives the idea that some other people said it wasn't due to the Coumadin, and she saw multiple specialists. Indeed, she continues on to say she saw multiple specialists, he or she. Took me 3 years. They spent 3 years on Xarelto and then changed to Eliquis. Thought that there was a lot of side effects with Xarelto. There was headaches, difficulty sleeping. There's some sleep apnea tests being done, inability to focus, short-term memory problems, insomnia. And then they took it off the Xarelto and became aware that insomnia was a side effect. Wasn't listed on the prescription insert. And there's some comments here about where to get they sort of manufacturer's insert. And some concerns about lack of availability. I can tell you those are, available even online these days on the internet. So you can get a full package insert, just by going to their websites typically. All right, so then it says, my question is, if I was allergic to Coumadin, and had side effects to Xarelto, and having side effects to Eliquis, but suffering from a symptom not on the company brochure, is it possible that my body is just allergic to blood thinners in general? So that's kind of a big, broad question. And let me read the last paragraph here, and I'll let you see what your thoughts are. Walkabout. Have a good walking program, several days a week, several miles each day. And I guess the patient's joint pain became worse on Eliquis. And so she's not able to walk as much as she used to because her hips and knees joints are hurting, and her current doctor thinks maybe it's related with the Eliquis. So I guess the questions are. So I guess I see three different questions. One is, this concern of joint pain with Eliquis. Two is this idea of overlapping adverse effects of medications. And the third was this where to get the package insert piece, which I think we answered that one. That we can find that online at the companies. If you just go to their typically these days you type in their drug name, and you'll find a website for their drug, and then you can look under the healthcare provider section. You can usually find the full package insert. Yes. But yeah, what's your thoughts on these questions of adverse events overlapping between medications? I think part of the question here is this idea of, is there a common intolerance that is inherent to all blood thinners? I think it's kind of what that question is saying there.
Yeah, well, Jim, you'd probably be a little bit better answering this given your experience than I, but I'm not aware of a crossover intolerance to anticoagulants unless you are, Jim. But this is a very complicated and situation, and I know how frustrating it might be in order to need an anticoagulant, yet you seem to have problems with several of them, but there are a number yet available that might be the right drug for you. And again, this is going to be a long-term and problem that you and your physicians need to work through in order to get you on the right drug for your particular situation. I don't know if you have any other comments, Jim.
Yeah, I mean, I agree. I mean, just so challenging for patients like this patient to hear that. In that, to me, it's the category where the body doesn't read the textbook, so to speak. The body doesn't follow the science that we're familiar with, I think is the way to say it. And so unfortunately, what happens in those settings is a lot of times the patient gets dismissed by the doctors because it doesn't match what we know. Therefore, they figure, well, maybe it's probably nothing to do with the drug. And certainly, there can always be adverse events from drugs. And it's interesting, right? Because the blood thinners have a very favorable side effect profile, right? Most people, other than potential bleeding problems, right? Most people don't usually have symptoms, and so with the infrequency of having some sort of problem, while it's always possible that any medication can cause any sort of side effect or adverse effect, it's really hard to know the true relationship whenever that happens infrequently, right? And then so that leads you to that challenge, and then the idea then of knowing if there is a side effect that is causing a patient, if the patient has what's an uncommon side effect from a medication, then the idea that we'd have any idea of relationship with other medications when it's so infrequent really becomes very challenging for us, right? I mean, it becomes next to impossible.
Yeah, absolutely. But again, I feel badly, or I completely can empathize that this is a difficult situation when you want to feel better and you need an anticoagulant, that this may be a problem. But again, there are a number of anticoagulants currently available that may be a better fit for that individual, and I would just keep on working with your physician to get you on the drug that is best tolerated. So
let me ask you one more question. Obviously, I said an agenda was too aggressive, as I always do, but we'll certainly pick up on the other ideas that I had at our next session in 3 months. But before we go, let me ask you one other idea, and this is this idea of, we talked about testing, we talked about the there's certainly things that we can do, and we talked last time about surgery, and we'll talk next time more in depth about other things we can do at the referral centers. But this transition from, you get diagnosed as potentially, or, whether it be clearly or just potentially having, CTED or CTEPH, and you get a referral to a center, conceptually, to two thoughts. One is, if patients are concerned and more than their doctor, and they want to drive that, how might they approach that to get that referral, or to get some get some movement along? If they feel like they have symptoms, they're not fully understood, they're concerned about, how might they get that moving along to get to a referral center with more experience with these patients? And the other question I have for you is, from when I talk to patients and yourself, there's a lot of repeating of testing that's done at the referral centers. Is that changing, or do we see that changing as there's more ability to share actual images between centers and people are on more unifying a medical record? Do you think that'll change over time, or are you seeing that change so that people don't have to go through the same tests again? What's your thoughts on that?
Yeah, I think, again, these are very good questions. And, this is an age in which a tremendous amount of information, some right, some wrong, is available on the internet. Pulmonary Hypertension Association is a good resource for patients for seeking out the information as where one goes to help them with dealing with the possible diagnosis of CTEPH. There are websites, if you put CTEPH.com, that'll give you further information on the diagnosis. Hopefully soon, within the year, the United States CTEPH Association will develop, which will be a patient advocacy group in order for folks to have access to actual medical centers that have expertise in CTEPH. And so, again, if your doctor does not know, there are places, there are websites to reach out to seek out the information as where locally you might find a center that has some expertise in chronic thromboembolic disease. And if you can't find that specifically, there is a tremendous amount of information as what pulmonary hypertension centers of excellence are available in your community. And those physicians will clearly know where the expertise lies in CTEPH in the region that you are residing. What I would like to do at our next session is actually talk about this issue. Where do you go to get help for CTEPH, and what help is available? As I mentioned, there's a tremendous amount of information on the internet that is not entirely correct. And there are so many more options now other than surgery for treating patients with chronic thromboembolic disease and CTEPH. And I want to provide those who are attending this webinar some information that hope might clarify some of the confusing information that is out there. Is, you know, when do I do a catheter procedure, or when is it indicated just for medications, and do I really need to have surgery? And I think that I would like that to be the focus of our next webinar. And to address the issue that you asked, Jim, about whether or not, you know, are tests necessary to repeat, or am I seeing less of that happen in the United States? And the answer is yes, when information is readily available. However, folks need to also understand that if you're going for an evaluation as to what is the most appropriate treatment plan for them, the physicians at the expert centers really need the most accurate and updated information possible in order to make that correct decision. So yeah, sometimes, let's say an angiogram that was done in another center just is not of the quality that is necessary in order to make the right decision, and something like that may be repeated. And that's just okay, because you're in the hands of experts who really need that kind of information to make the best possible decision for you. And so that kind of stuff should be tolerated. But there are some studies like blood tests or lung scans that don't really necessarily need to be repeated. And I think centers of excellence appreciate that. They know that, you know, what to repeat and what not to repeat. And I'm very impressed over the years by going to centers around the country that people are being very thoughtful about this and not wasting time, money, and basically the patients, good patients in repeating studies that don't need to be repeated.
Very, very good. Yeah, no, I think that as long as, I understand the frustration of patients when they feel like they are getting the same test again, but at the same time, usually I find if you take the time to explain to them why it adds value,
and ask the question. Just ask the question, and a good expert center, you know, the docs are going to give you the answer, and you deserve an answer to that question.
Yeah, very good. All right, well, our hour is up. I think, as you point out, next time we'll start with those two key questions: where do you go for help, and what help is available, and we'll work our way through those, and then we'll go from there.
Sounds good.
All right.
Okay. Wonderful. Thanks so much, everyone, and we'll be in touch as soon as we have a date set for the next CTEPH support group.
All right.
All right. Thanks again, everybody. Take care.
Thank you. Bye-bye.
Bye-bye.